Hello, HHT community, and welcome to our latest webinar. My name is Riley Blevins. I'm the Senior Director of Global Community Engagement here at Cure HHT, and I will be moderating tonight's session. Today, you will have the opportunity to learn all about a newer treatment option that is helping many HHT patients manage chronic nose bleeding, that being sclerotherapy. In this session, you'll learn all about the technique, who it helps, the pros and cons and considerations in which doctors are currently using this treatment. But first, before we jump in here today, I want to make you aware of some news and announcements going on here at the organization. We're excited to launch several new programs here at Cure HHT, but I also want to remind you of some programs that we already have underway. First up here is HHT Connect, the first ever global HHT patient registry. Our goal here is simple: to collect health information from as many HHT patients as possible so that researchers and doctors can discover patterns and clues that can help them better understand HHT and develop new treatments. By answering a handful of simple questions, you can advance HHT research and do so all from the comfort of your own home. I would strongly encourage everyone here tonight to please go to our website, learn more about HHT Connect, and consider signing up. Our next program has been highly requested for years, in fact, but earlier this year, we're proud to have launched our HHT Continuing Education Hub. Thanks to this platform, providers seeking to further their HHT knowledge can receive continuing education credits at any time when they complete a course online. While these classes are geared toward medical professionals, patients, you can play a critical role in advancing HHT awareness by sharing this information with your local non-HHT doctors today. Please visit our website to learn more. Our next program is a research study for those patients enrolled at select U.S. HHT Centers of Excellence. CHORUS, which stands for the Comprehensive HHT Outcomes Registry of the United States, seeks to better understand HHT, the symptoms and complications it causes, and the impact the disease has on people's lives. Investigators are collecting long-term information about patients, allowing them to understand disease factors over time. To see if your center is participating, please visit curehht.org. Our webinar today is brought to you by Bleed Cease. Stop bleeding fast and easy. Click the link in the chat to receive a free sample pack of Bleed Cease. We thank Bleed Cease for their generous support and partnership and their help in making programs like tonight's possible. Also, if you haven't heard already, we recently expanded the criteria for our newest clinical trial, the Piccirillo study. Check out our website for more information and to see a recording that will help answer all of your questions. If this trial is successful, this has the potential to be the first ever HHT approved therapeutic, a major milestone, but we need more participants in this trial. Visit our site to learn more. We have several other research projects underway you should know about, and you can learn more about things like the Brain Vascular Malformation Consortium and tissue donation by visiting the research section of our website. I also want to remind everybody here that Giving Tuesday is right around the corner. This is the largest global day of giving and a significant fundraising day for us at Cure HHT. This year, we're thrilled to announce that every dollar contributed will be doubled thanks to a generous group of donors. Now, you don't have to wait until the big day on December 3rd to donate and get your gift match. Please consider donating today, and every dollar, it truly makes a difference. Simply put, we could not continue our mission and work without the support of this community. Finally, if you're not already, please be sure to subscribe to our emails and follow Cure HHT across social media platforms. Simply put, it's the best way to stay up to date on the latest HHT news, like today's major announcement that you may or may not have seen. Earlier today, Vidaris Therapeutics, we've been working with hand in hand for quite some time, announced it has received a fast-track designation from the FDA for their novel HHT treatment. Hear about news like this and more fast by following us. Visit our website for more information. Finally, before we officially get underway, I want to go over some housekeeping rules for the webinar to make this event as interactive and successful as possible. If you have a question for our presenter tonight, please type it into the Q&A box to the right of your screen. We recommend that you keep your questions general in nature so they benefit everyone. I will ask as many questions as time allows. We will post resources relevant to tonight's topic in the chat box. You can use that chat box to make comments to either an individual or all participants on the webinar, but as a reminder, please do not post questions for the presenter in the chat box. Questions go in the Q&A box. This presentation is being recorded and a recording will be saved in the Cure HHT website's resource library. And at the end of the discussion, you will be emailed a survey. Please do take a few minutes to fill that out as your input is critical for the development of future webinars. And with that, let's get going here. It is my pleasure to introduce tonight's speaker, Dr. Jay Piccirillo. Dr. Jay Piccirillo is an otolaryngologist, clinical epidemiologist, and health services researcher at WashU HHT Center of Excellence. He has several clinical research training programs at Washington University. His current research focuses on empowering cancer patients with relevant prognostic and treatment effectiveness information and studying the neurobiology of tinnitus. You might have to correct me, Dr. Piccirillo, if I misrepresented that. He has been with WashU for over 32 years and been treating HHT patients for many of those years. Also, I would encourage everyone on the webinar here tonight to get your phones ready, as Jay will have some QR codes that might be useful to scan during his presentation. At the end of the presentation, we will hold a 20-minute moderated Q&A session, so please do take advantage and get your questions answered. With that, Dr. Piccirillo, I appreciate you being here tonight, and I will turn things over to you. So please turn your camera on and unmute yourself.
Riley, can you you cannot start your video because the host has stopped it.
Strange. Courtney is running IT in the background for us. Maybe that's something she can take care of.
There it goes.
Oh, got it.
Hi, everybody. Thank you, Riley, for the nice introduction, and thank you to the Cure HHT Foundation to allow me to do this webinar tonight about the sclerotherapy procedure. Let me share my screen. How does that look?
Looks great.
Great. Well, let's go ahead and get started. I'd like to really go through the whole process of sclerotherapy, something that I've been doing since 2009. As Riley said, I came to WashU in 1992 and have been taking care of HHT patients ever since. I did 2 years at Yale when Bob White had started the HHT Center there in the late 80s and early 90s. So I've been in the HHT community for, as Riley said, almost 30 years, and I've just enjoyed so much that time and doing what I can to help out. And I do think the sclerotherapy, from our perspective as otolaryngologists, is really sort of a breakthrough therapy for nosebleeds. And without further ado, let's go ahead and get started. The Cure HHT Foundation sponsored this second international guideline for the diagnosis and management of HHT. And I was fortunate to be part of that. And our expert panel recommends a variety of therapies for nasal telangiectasias, including electrotherapy and sclerotherapy. So this was the first time that sclerotherapy was recognized as a expert-approved treatment for epistaxis. Well, what is sclerotherapy? Sclerotherapy involves the injection of a sclerosing agent. This sclerosing agent causes irritation in the inner linings of the blood vessel walls. The walls then are pressed together, causing the blood vessels to close. And then scar tissue takes over to keep that blood vessel closed. The inflammation gradually solidifies, forms a scar, and that takes about 6 months to complete. But quite clearly, the actual stopping of bleeding happens within minutes of the injection. And I'll show you some examples of bleeding that stops with injection. Here we are at Washington University HHT Center of St. Louis in St. Louis. As I mentioned, I've been doing sclerotherapy for HHT-related epistaxis since 2009. I went up to Minnesota and learned from Dr. Holly Boyer, who had been doing sclerotherapy for some time, and invited me up to see what she did. And so I've been doing this since 2009. I've performed sclerotherapy on well over 200 individual or separate patients. I performed the procedure at least 1,000 times as Each patient oftentimes will receive multiple procedures. On average, I perform about 2 sclerotherapy procedures per week. Sclerotherapy can be used to treat telangiectasias in the nose, mouth, tongue, and skin. Sclerotherapy is recommended when nosebleeds significantly interfere with daily life, enjoyment, employment, or other responsibilities. I call the Sclerotherapy Center at Washington University an on-demand sclerotherapy center. In other words, when the patient demands to have sclerotherapy done, we do it. It's not like you have to have a certain score on your epistaxis severity scale or your nose HHT instrument. It's really dictated by you, the patient, deciding that the nosebleeds have become too much of a problem, or perhaps you've got a big upcoming event like a wedding or travel or something. You just really feel like you want to have the sclerotherapy to provide some of that, not a guarantee, but just a better feeling that the nosebleed won't interfere with some important upcoming event. The sclerotherapy is effective for telangiectasias, really all over cutaneous skin and mucosa surfaces of the mouth, the nose. I'll use sclerotherapy for people who've had multiple cauterizations in the past, electrocautery, laser cautery, septal perforation, sinus surgery. Sclerotherapy is very handy and very hardy to be used in all different types of situations. Can be considered post-bevacizumab treatment, and as I mentioned, laser surgeries and perforations. Some of my patients will have, iron deficiency anemia from the number and severity of their nosebleeds, and sclerotherapy will help with that. Or with my partner, Dr. Chakanali, who runs the HHT clinic here at WashU, we might even use sclerotherapy in anticipation of a patient going on a blood thinner for atrial fibrillation or some medical condition. And Dr. Chakanali will ask, and the patient will maybe ask, if sclerotherapy will help decrease bleeding once the antiplatelet therapy begins. I believe, the medicine I use, Sotradecol, should be available in Canada, and it's certainly available all throughout the US. As I mentioned, as you'll see, I do the procedure multiple times in people anywhere from 3 months apart, 5 months apart. Every year, someone will come in. Some of my patients will come in for touch-up procedures. So let me segue and talk about the procedure itself. So preparation for the procedure. Well, I basically consider performing sclerotherapy on patients age about 15 or so and older. They have to be able to hold still and in a chair under local anesthesia. Really, all the procedures that I do now are in the office with local topical anesthesia. So if a patient's unable to tolerate local anesthesia, like at a dentist's office, then maybe that would be a situation where general anesthesia is required. But this is the type of setup. It's an office-based procedure in our ENT clinic. General anesthesia can be used, but it's really not very common, or definitely is not necessary. This is what the instruments look like that I use. These are called the red merit syringes, 1 and 3 cc syringes. They're special syringes because they slide very easily. And you'll see why that's important when I show the foaming and the sclerotherapy. We then use a 3-way stopcock, and I'll show you how that works. 25 gauge butterfly needle. And then we use Sotradecol, sodium tetradecyl sulfate, Sotradecol 3%. It's very, very easily to get. It's the product that's used for varicose veins of the legs. So it's, again, used in a lot of quantity for varicose veins and other types of vascular lesions. And then we mix the Sotradecol with air, and I'll show you how that works in the next slide. So these next 2 slides are from Dr. Holly Boyer, University of Minnesota, and this is her assistant, and this is where I got the videos from. So there you see the assistant mixing the Sotradecol with air to make the foam. So the key to what I do is this foam sclerotherapy, low pressure foam. Okay, when the assistant says she's ready, in other words, the foam has reached the right consistency, Dr. Boyer here will go ahead and identify the telangiectasias that she feels are problematic and that she wants to inject with the foam product. And you'll see this is a 3 cc syringe that originally had air in it. This is a 1 cc syringe that had the Sotradecol. Her assistant closed off the 3-way stopcock to the needle, if you will, mixed back and forth to get the foam, and now she's ready to help Dr. Boyer deliver it to the telangiectasia, as you'll see next. Here we go. And watch the assistant's left hand as she turns the stopcock to open up to the patient and deliver the foam. There she goes. She's opened it, and now you might want to watch the little air bubbles in the foam moving along. And the assistant will tap a little bit. She opens it, taps, and then closes it. Dr. Boyer will go to another telangiectasia. The assistant will open, tap, and the foam just kind of moves along.
See it go through it? Do you see that light? See it flashing through?
Good. So this is about a 3-minute video that I've put together. It goes over some of the material that I just showed you, meaning the actual equipment I use, but it also shows how I do it here at WashU in St. Louis, very much like what Dr. Boyer does. At the end, I'll show a QR code that'll take you to this video on YouTube. And so if you want to show this to your physicians, you can do that. So this.
And you're gonna drop 0.6 of the medication. And then in the 3 cc syringe, you're gonna draw up 2.4 cc's of air. Connect them with your stopcock. One cc goes on the top. The 3 cc on the side. And then you're gonna add your wing infusion. Where we would connect this to a needle.
So what I like to do is cut the flanges. As shown. You can drive or some instrument. Small piece left.
So to mix it, you just go back and forth until you hit the white foam. And you'll feel a little pressure building in the 1 cc syringe. And then once you can feel that, you're ready to go. And you can open it, and then you'll open it. And feed the foam through so that it makes these nice fluffy bubbles.
I go very superficial, just barely under the skin and into the telangiectasias.
Yes.
There, you can kind of see the white bubbles under the skin. So this QR code will take you to the YouTube video if you'd like to do that. This next video shows a combination of electrocautery and sclerotherapy. So you're going to see a little pumper up here. This is what happens inside the nose. For those of you that have the really bad nosebleeds and it seems like it's pumping out, this is what the pumpers look like. Right there. You can see it pumping with the heartbeat. So this is cautery, bipolar cautery in the operating room, and I'll cauterize by putting the tongs on either side of that bleeding vessel and then step on the electricity, and it burns it. It's a little cautery. And then in the process of doing that, another one opened up a little bit further behind. There you go, number 2, right back here. And so I cauterize that. But I also felt that there were probably more blood vessels under the surface, and so I felt this was a good situation. There's a pumping again, still going. That would be very hard to control at home, obviously. So I decided to use sclerotherapy into that wound bed because I just felt there's probably a plexus of vessels underneath there. So here comes the needle with the sclerotherapy in the operating room. I use sclerotherapy here. Great. So the description of aftercare is really quite straightforward. Very little pain. I only recommend Tylenol for any discomfort, but few of my patients report any discomfort. So it's minimally invasive, and the medication is injected just below the skin, barely deep enough to cover the bevel of the needle. One injection generally treats the telangiectasia completely, although for larger lesions, and I'm going to show you an example from a lip, larger lesions may need multiple injections. Multiple sessions are possible and oftentimes are required. Long-term results, the treated site remains very healthy. And that's the one thing that really struck me out when I started using sclerotherapy as compared to what the nose looked like after laser and electrocautery. The sclerotherapy mucosa looked so healthy, pink and normal. There was no signs of all the trauma and injury that I would oftentimes see after using laser and electrocautery. So it's very, very impressive how the wound site looks so healthy after sclerotherapy. Now, as you'll see, or as you see, many patients will have multiple telangiectasias in the nose, and for a variety of reasons, including safety and not wanting to use too much medication at one time, I won't try to inject all the telangiectasias, and so obviously the patient can bleed from the telangiectasias that I haven't injected, and the patient can develop new telangiectasias. Not usually where I've used the sclerotherapy, but certainly what I say is sclerotherapy is not a cure. You'll continue bleeding either from sites that I didn't inject or new telangiectasias that developed elsewhere. I'd like to describe my experience at WashU. So again, I started this in 2009, and from 2009 to 2014, I was using Sotradecol, and I was mixing it with saline, not air. And that's the way the interventional radiology at Washington University used Sotradecol for all the different applications in other areas of the body. And so, again, for the 5 years from 2009 to 2014, I was mixing Sotradecol with saline. I did about 58 separate patients, 230 or more procedures. Here's a medium age, 76 had history of cauterization prior to Sotradecol. My complications were very few, except I did have the one patient who experienced a unilateral vision loss. Obviously, that was very disturbing. And my response was to stop the program and reevaluate the procedure and what it was that I was doing, and was this safe to continue? And what I did is I visited Dr. Boyer back in Minnesota and kind of went over what she had been doing, spoke with her interventional radiologist, spoke to physicians around the country, and really made the decision to change from mixing Sotradecol with salt water, saline, to mixing it with air, and I call that the Boyer technique. And from 2015, this is 2023, of course, I've done several this past week, so I haven't really updated it to 2024, I apologize, but I now mix Sotradecol with air, done over 500 procedures, over 150 unique patients, and a conservative estimate, 150 unique patients. And then this graph, you see the number of procedures per patient. So, many patients will have one, but a bunch will have 2, 3, 4, or even 12, 13, 14 procedures now. I've been doing this long enough that if patients come back every 6 months or every year, yeah, we're up to double-digit procedures. Complications, I had one patient who got lightheaded and kind of felt like he was going to pass out. We call that a vasovagal response. One patient complained of excessive pain at the injection site. One patient had some excessive bleeding that was controlled with pressure. One patient had a little bit of an exaggeration or exasperation, worsening, if you will, of ocular migraine. But I've had no cases of vision loss, septal perforation, transient ischemic attack. It's like a little mini stroke or anaphylaxis. It's just been really, really well tolerated. And I think there's, some lessons that I've learned, some things I like to share with regards to concerns about blindness associated with sclerotherapy. There are numerous listed here, other compounds that are associated with blindness, including using your own fat to inject into certain areas around the face as cheek fillers and things like that. The incidence of blindness for these types of compounds is maybe 1 in 5,000, 1 in 10,000 procedures. It's hard to get a good estimate because it is so rare. About 190 reported cases globally from 2000 to 2018. Some common misunderstandings about sclerotherapy being risky. So the origin of that concern comes from episodes of blindness, and I had one myself, unilateral blindness. It's rare but possible. I tell that to all of my patients. It's rare. I will inject Sotradecol in patients that don't have HHT but are bothered by nosebleeds. I've injected Sotradecol in patients who are blind in one eye from a childhood injury or other events. I've injected sclerotherapy in my wife for persistent nosebleeds, all the while knowing that blindness is a possibility. And what we do, and what Dr. Boyer preaches, if you will, is the safety margin comes from dealing with experienced professionals, delivering the sclerosing agent under low pressure. That's what the air and foam helps us to do, is to keep the pressure low. You don't want high pressure. You don't want to be squirting this material into the nose or anywhere really in the face or body, because that will force the medicine to areas that you don't want. You want that sclerosing agent to stay right in the telangiectasia. So you use foam, low pressure foam, and I inject, and Dr. Boyer teaches to inject very superficially into the mucosa in the skin, thereby again decreasing the chances of it going elsewhere in the nose or face. Let me move on. I want to show you how sclerotherapy can be used on other telangiectasias. In this case, it's the lip. So you can see a classic telangiectasia on the lip, and this is before sclerotherapy. This is immediately after. You can see a little black and blue, if you will. And this patient was kind enough to take pictures of her lip as the sclerotherapy injection site resolved and the telangiectasia resolved. So here is about 8 days after, 140 days. So that's probably about 3 or 4 months. This is without lipstick. So it's really very, very nice. And really, my first choice for skin lesions on the face, cosmetic lesions, or for men, you know, shaving and bleeding, earlobe, turning over in bed and rubbing your earlobe on your pillowcase and causing bleeding, tongue, eating, cutting on paper, potato chips, things like that. I will definitely inject the tongue, hard palate, soft palate. There's another patient with a lesion on the lip. Okay, so this is after a second procedure. So I didn't inject a lot of medication throughout here because I didn't, want to get complications. So I just gently injected maybe a little bit of Sotradecol here, a little bit here. This is what it looks like after the third procedure, quite a bit smaller. Fourth procedure is right here. And at this point, he said he was fine. I mean, I could have injected these 2 areas, maybe 1 or 2 more, and basically get it right back to normal skin. He said, no, I'm good. Thank you. So I've been really enjoying the sclerotherapy training program that we started here at Washington University with support from the Cure HHT Foundation and the HRSA grant, which the federal government Health Research and Services Administration gave a grant to bring ENT physicians, primarily those located at centers of excellence, but other ENTs who are interested in the procedure. So this slide is really meant for the professionals, but I wanted to share with you so that hopefully you could share it with your ENT professionals about the sclerotherapy training at Washington University. So it's an all expense paid training trip to St. Louis. Myself and Dr. Chakanali, who's our medical director of our WashU Center. Training's available for 5 participants this year. Interested parties should fill out a form. That can be obtained at the Cure HHT Center, or they can contact me. Training involves presentations, hands-on practice with grapes, and then observing the sclerotherapy procedure. St. Louis is centrally located. People fly in midday on Monday. We go out to dinner and we talk about our whole therapy approach. Tuesday morning, we practice on grapes. Tuesday afternoon, I do my procedures with my patients. My visiting professors or visiting physicians observe it. By about 3 or 4 o'clock, they're on their way out to the airport and they're back home by 8, 9, 10 o'clock. This is Dr. Jacob Fisher from UCLA out in Los Angeles with my medical assistant, Tracy Wright. And you can see the grape right there. Tracy's mixing it up and going to show Dr. Fisher how we do that. In August, we had Dr. Tran Locke and Dr. Mihan Fox from Baylor College of Medicine down in Houston, Texas. And now we're trying some more grapes here, and they're getting the hang of mixing the foam and getting that low pressure foam, which is so key to the success of the procedure. Last month, we had Dr. Jay Pinto, Dr. Elizabeth Blair, and their medical assistants from the University of Chicago come down, and there are grapes, and everyone's having fun injecting grapes. And Tracy, once again, is showing how she does it. So I'm really pleased to show you a map of the United States and to outline the physicians who perform sclerotherapy. Of course, myself and my colleague, Dr. Nissa Farrell, do sclerotherapy. Holly Boyers, who I learned from in 2008. Dr. Alan Whitehouse in Augusta, Georgia, the Center of Excellence in Georgia. Troy Woodard is at the Cleveland Clinic. Melissa Pinion and her colleague Jeff Terrell at University of Michigan. Melissa came to WashU and participated in the training program. Rhonda Haymaker in Indianapolis, Indiana. Jeb Dustis at University of Florida, Gainesville Center of Excellence. Jacob Fisher, who you saw. Meehan Fox Tranlock at Baylor in Houston. Dr. Patricia Loftus came out. She's at UCSF in San Francisco. Jay Pinto, Elizabeth Blair, University of Chicago in Chicago. And finally, we have scheduled next month Blair McRae from University of Utah, Salt Lake City to come out and watch. So we're really thrilled that we have so many people. We're looking to get the Eastern Seaboard, maybe Boston, New York, Philly kind of covered, Baltimore. That would be wonderful. Encourage your physicians, for those of you who go to centers on the East Coast, to think about coming out. We'd love to show them the program. And as I end, I just wanted to put a pitch in for the NOSE HHT patient-reported outcome measure that we created here at WashU, again, with assistance from the foundation, allowing us to post on the Cure Foundation website, which got, 200 or 300 HHT patients within a week, that allowed us to create, develop, and validate this patient-reported outcome measure that rates the physical problems, functional limitations, and emotional consequences of epistaxis. This QR code will take you out to an app that allows you to keep track of your NOSE HHT scores by entering it over time and allowing you to see how it changes over time. So that ends my presentation. I hope this is helpful, enjoyable. I'd love to take questions from you all. Thank you so much for your time and attention.
Thank you so much, Dr. Piccirillo, for the time here tonight and thorough presentation. I hope everybody on with us here today enjoyed that presentation. We'll now begin the Q&A portion of our webinar here tonight. So if you do have a question for Dr. Piccirillo, please do take advantage of this time. It looks like we have a few coming in now. We'll get to as many as time allows. We have one from Eric here who is asking, is the nasal lining irritated, swollen, and is there scarring in the septum post-sclerotherapy?
So really, in a word, no. I mean, it's just really well tolerated. Occasionally, I'll see a little black and blue from where I injected, but oftentimes not. Minimal swelling, none that I can see. Maybe the patient feels a little swelling, but no. And as I said before, the tissue looks so healthy afterwards. There's no signs of scarring or sort of that look that I often saw in my patients, where I would use the laser or use the cautery, the electric cautery, and you'd get that thick scar look. Or my goodness, we used to do this dermoplasties and we'd take skin grafts, and no, nothing like that. The nose looks so healthy. As you saw from that lip sclerotherapy, I mean, her lip just returned to perfect. And that's really what I expect to see with sclerotherapy over time.
Thank you for that answer. We have another question coming in from Michael, who is asking, what kind of qualifications are required in order to perform sclerotherapy?
I would say that any board-certified otolaryngologist should, and probably dermatologists on the skin or vascular surgeons, should all feel comfortable using sclerotherapy. But particularly for nasal telangiectasias, again, all board-certified otolaryngologists will feel very comfortable with this procedure.
Thank you. We've had this question asked a lot of times, both in our pre-survey and coming in live here tonight, but asking if sclerotherapy is available in Canada has been a very common question.
And I don't really know the answer to that. I have no reason why it wouldn't be. The drug Sotradecol should be available. I work with a lot of colleagues over in Europe, Italy, France, Spain, Germany. They're all using it. So again, without really knowing for sure, I can't understand why it wouldn't be. It's really identifying a physician who would be willing to do it. And again, our program, our sclerotherapy training program, is available to physicians up in Canada too. So please ask your physician to think about it and contact me directly. I'd love to work with them.
Thank you for that. We have another question here from Dennis. It looks like a two-part question. Part one is, how well does sclerotherapy work for posterior lesions? Part two, can you describe the difference in long-term outcome between laser cautery and sclerotherapy.
Okay, so so the question about posterior telangiectasias, those are challenging. Those are difficult. I do not inject posterior. That would be anywhere from the mid part of the nose back to the throat. Certainly wouldn't do that in the clinic because it's really hard to get back there. As anyone who had those type of nosebleeds know, it's challenging just to keep breathing and not spitting out the blood. It's just very, very challenging without the patient under general anesthesia. So, right, 20 years, I would use general anesthesia with the patient intubated to protect the airway. And yes, I did use sclerotherapy in the posterior nasal cavity. So the answer is yes, it can be used in the posterior nasal cavity, but I would only do it under general anesthesia. I don't do that in the office. And Riley, the second question.
Sorry. The second question, yeah, it was long. It's can you describe the difference in long-term outcomes between laser cautery and sclero?
Yeah. So again, I don't have a lot of experience with laser. I use electrocautery. Again, how little long-term scarring is associated with the sclerotherapy as compared to what I would see the burning and the scarring after the electrocautery. Those are really the big differences. And I do think that the electrocautery causing trauma and burning could have possibly even encouraged new telangiectasias, because I think a lot of us believe that the telangiectasias occur for a variety of reasons, including trauma or injury. And because electrocautery causes trauma and injury, I think we might actually be creating new telangiectasias, which I do not experience with the Sotradecol.
Absolutely. Thank you for that. It looks like might have just answered two questions here from Chris and Julie, but I'll repose them. Chris is asking if bleeding develops at the site where sclero was performed, and Julie is asking for factors to consider when debating between sclero or coblation.
Okay, so sure, when I inject the medicine in the nose, I'm obviously sticking a needle into a bloody telangiectasia. And yes, it bleeds. And so we put a bib on, and it's great when our patients come with dark shirts on or ugly shirts or their favorite bleeding shirt, because they are going to bleed. But it stops. And it stops both because of the Sotradecol, because of the sclerotherapy, because of pressure. And that's not a problem. And in fact, when I see pumpers in the office, those bleeders, even in the mouth and mucosa, I will inject Sotradecol right to the site as a way of controlling the bleeding. So yes, the needle stick causes a little bleeding, but overwhelmingly the Sotradecol almost immediately stops the bleeding. And with regards to coblation, I do not have any experience with coblation. My colleague, Dr. Nissa Farrell, will use coblation when she takes the HHT patient to the operating room. Which one is better? I don't think we can really answer that. They're like two separate instruments that kind of are used in different settings. But I think the overwhelming tool to have in your bucket is the sclerotherapy tool. It has a lot more versatility, a lot more uses than I think coblation. And as so many of my patients say, they appreciate the sclerotherapy as an outpatient procedure where they don't have to undergo general anesthesia. And, that's probably the second most common compliment I get. First is, thank you so much, Dr. Piccirillo. It's really helped me stop the bleeding, live with my bleeding. And then the second is, and I really like not having to undergo general anesthesia.
Thank you for that. We have an interesting question coming in from Anthony, who's asking if sclero on the tongue affects taste.
Great question. Not that I'm aware of. I've done a fair enough of them, and I've never had a patient complain about that.
Thank you for that answer. I'm scrolling through the remainder here, answered a lot of these in the presentation, and everybody will get a recording of this if you registered here today. Let's see. Kathleen is asking, can the procedure be done when someone is on an anticoagulant?
Yes, it can. And we expect bleeding. So as I mentioned in my presentation, I'll oftentimes use it before the patient goes on anticoagulation to help kind of decrease the bleeding once the patient started. But yes, we can also use it while they're on anticoagulation. Everyone's a little bit heightened anxiety, and but yes, we will do that. Especially if there's an identifiable lesion like up front or somewhere that the patient says, doc, it's always bleeding right from this area. That's great. If it's kind of like, I'm not sure where it's coming from, the whole nose, that's a little bit more challenging. But absolutely, I wouldn't say no because the patient's on anticoagulation.
Wonderful. We have Robert and David both asking similar questions here, which is how often can you have this procedure?
Oh, quote unquote, as often as necessary. I mean, every 2 weeks. Obviously, that's not ideal, but sometimes it'll take that, especially for the bigger lesions. You saw that the second lip example. That's quite a large lesion, and it took multiple times to take care of it. So if presented with a large lesion, I'll say, we're going to do a little bit today. We're going to do a little bit in a couple of weeks, if you're agreeable. And then, we'll go from there. Other patients will come in for touch-up, every 6 months, every year. For the women, I kind of use the example of curling or perming your hair. You look beautiful after a perm, but guess what? It all grows out. So in a similar way, the new telangiectasias will grow in, and you need to do it again. Another example is, weeds in your lawn. You throw down the weed killer, you get a 75% weed kill. That's great, but you still have the remaining weeds that will begin to grow, and you've got to then throw down another application. And so I think that somehow maybe hopefully explains my philosophy about how often to use it. But at the end of the day, it's really driven by how often the patient wants the procedure done. It's on demand. And so when the patient calls and says, I need the procedure, I don't say, well, how much have you have? And I say, great, when can we see you? And then the first thing I do is look in the nose and see if I can identify telangiectasias to inject. And about 10% of the time, I don't. And I say to the patient, I believe you, I know you're bleeding. I just can't find any place to inject. And I don't just randomly stick sclerotherapy when I don't know what I'm doing. So, again, about 90% of the people who show up, sure enough, there are lesions that we can inject, and I do.
Absolutely. To that end, a similar question, and likely the last one here for the night is, how many lesions can you treat in a session?
Yeah, great idea. Great question. Don't want to overload on medication. So I'll refill, or Tracy, my assistant, will refill maybe twice, at most 3 times. She adds 0.6. So 0.6 times 3 would be 1.8 cc's. How many lesions? Well, maybe 3 on the septum, 3 on the turbinate. That's the lateral side of the nose on one side. So 6 on one side, maybe the same on the other, maybe a max of about 12. And then the patient will say, but I got one here, I got one here. So now we're up to 14. But I do have a little sense inside my head about not wanting to inject too many for safety reasons. And so, maybe 3 on the inside part of the right nose, 3 on the outside part of the right nostril, and 3 and 3 on the other. So for a total of maybe 12. But I can't remember the last time I really injected that many.
Absolutely. That will conclude our session here tonight. Dr. Piccirillo, I want to thank you for generously donating your time and for the thorough presentation. Moreover, for the work you've done on behalf of the patient community and the work to grow access to this treatment. That slide you saw earlier with the map and all those stars of physicians who do sclerotherapy is a result of your work and generosity. So we thank you for that. To the patient community, thank you for being with us tonight. You will be receiving a survey after this webinar. Please do take a minute to fill that out. We take your feedback very seriously and helps us inform what sessions and topic areas are of interest to you and will best help you throughout your journey with HHT. On behalf of all of us at Cure HHT, we wish everybody a great evening. Thank you.
Thank you very much. Good night.